So this is the third module of the cancer course, and this is all about cancer treatments and side effects. I'm going to go into the 8 main ways to treat cancer. There is quite a lot of overlap between some of them. The lines are a bit blurred, and there are some relatively common treatments that don't exactly fit into any of the main categories. So we'll sort of tackle that as they come up. So traditionally, up until really just a few years ago, the 3 pillars of cancer treatment were surgery, chemotherapy, and radiotherapy. And that was really it. Things have changed a lot, even just in the past 10 years, but unfortunately, a lot of the thinking in oncology hasn't changed. And that's really quite understandable if you think about it, because people fall back to their fundamental education. So if you have an oncologist who's experienced oncologist in their 40s or 50s, they went to medical school quite a while ago. And although it's very likely they've kept up with the changes in chemotherapy, for example, because that's the main thing an oncologist will deal with, their knowledge of radiotherapy, oncological surgery, and these newer treatments may be just things that they were taught at medical school. So, for example, when they heard about the new treatments we have now, when they're at medical school 20-something years ago, those were just all experimental or theoretical treatments. So an example of that would be the particle treatments. It's a type of radiotherapy using particles. When they were invented, which was actually a long time ago, like proton beam therapy, I think was, I say maybe 50s or 60s. They were invented before CT scanning. So they weren't really practical treatments because you didn't have good targeting, and you didn't have CT scanners to see what was going on. So you've got to be a bit careful when you're talking to non-specialist clinical staff about treatments. Your oncologist, should have some grasp of radiotherapy, but they might not know a lot of the nuances, and they may be given false information by various agencies, and they have to really take that on face value. I'm specifically thinking about proton beam therapy, where the National Health Service in the UK was strongly against proton beam therapy, at least on paper, until very recently. And all the oncologists were saying it's an unproven treatment that they're using abroad and they shouldn't be using. And there was a very high profile case, in fact, of a couple who took their child somewhere in Europe, I don't remember where exactly, for proton beam therapy, and this was seen as like a terrible thing in the NHS. And of course, now the UK finally has some proton beam therapy, and they are changing some of the content on the NHS websites about proton beam therapy. But just bear in mind, we're always dealing with old thinking when we talk about cancer treatments, and that's to a large extent unavoidable, because you compare cancer treatments by 5-year survival mainly, and the 5-year survival stats are the previous 5 years or the 5 years before that treatment became approved, and those stats update very slowly over time. So it's very natural that we're talking about the we're seeing history, we're seeing the past, and we're talking about it as if it's current when it's really isn't. So the 3 pillars of cancer care have always been surgery, chemo, and radiotherapy. But the big change, really, I guess, in maybe the past 15 years is the widespread use of molecular targeted drugs or targeted therapies. And then much more recently, immunotherapies, and particularly since 2017, is kind of the big change with immunotherapies, with these checkpoint inhibitors. So checkpoint inhibitors, the way the media explain it is they take the brakes off the immune system. That's partially accurate. It's to some extent a useful idea, that your immune system wants to attack the cancer. That's what the immune system is evolved to do, but it can't, because the cancer cells are not presenting the right labels, for example, and the cancer cells are ignoring signals from your immune system that they ought to be dying. So we talk about checkpoint inhibitors and PD-1 targeted drugs and PD-L1. PD-1 is just a program death 1, so it's just I think it's like a molecule on the surface of a cell that tells it to die. And then PD-L1 is program death ligand 1 or ligand 1, and that's kind of the receiving bit on the cell, I believe. So the idea with checkpoint inhibitors is that you can take the brakes off the immune system, and the immune system will then recognize the cancer and kill it all. This doesn't really work in practice the way that the media and the pharmaceutical companies tell us, because many patients have a lot of immune suppression. So there just isn't much of an immune system to do the attacking. So in my case, I've had this type of immunotherapy called adoptive cell transfer, where you're actually given far more immune cells. In my case, it was autologous, meaning grown from my own white blood cells, so that hopefully you don't get such a high percentage of those transferred cells being destroyed by your immune system. And also you don't get those dangerous allergic reactions that we hear about with, for example, CAR T cell or the checkpoint inhibitors. So having these targeted therapies available, that's really changed a lot in cancer treatment. Unfortunately, the thinking hasn't changed with it, and there's some kind of subtleties with that. So often patients are told they can't have surgery, or they're not eligible for surgery. Surgery wouldn't help in that case. And that's because historically the outcome for the surgery was maybe not so great and the risk was too high. But now with good molecular targeted therapies after surgery, it could often tip the balance towards surgery. So you do have to be a bit careful about that. So we've got surgery, chemotherapy, radiotherapy, the targeted therapies, immunotherapy, and you've got hormone therapies. Now, these are the ones I know least about. I really need to study a bit. Hormone therapies are used for example, prostate cancer, and the gynecological cancers as well, so breast cancer, ovarian cancer, those kind of things, that there'll be often hormone treatment there. Some people would kind of put them in together with targeted therapies, but yeah, the mechanism is a bit different. Then there's hyperthermia therapy, and this is one that is I think often dismissed by oncologists as maybe an unproven treatment or something like that, which isn't, it can't really be the case, because hyperthermia therapy is like a whole branch of oncology, and some types of hyperthermia therapy are very standard for all cancers. So ablation, where you're using heat to destroy cancer cells, that's used a lot for lots of types of cancer. The most well-known of that would be RFA, radiofrequency ablation. So that's often used when cancer spread to the liver, or when cancer spread to the lungs, it can be used. And that's when a special needle is inserted into the tumor in a non-surgical procedure. So you've got local anesthetic, you've got hopefully a load of sedation, but you're not under general anesthetic, so you're not kind of unconscious, and you don't have the kind of risks, the danger associated with general anesthetic. And the needle is then heated using radio waves to ablate the tumors. And that's, I think, fair, you could consider that type of hyperthermia therapy. There's a similar one where you use microwaves. For some reason that's called MFA, microwave frequency ablation, even though of course microwaves are a type of radio wave. Yeah, silly naming, but I didn't come up with it. So that's when you bring a tumor to ablation temperature, like the heat literally destroys it. But then there are things like HIPEC, heated intraperitoneal chemotherapy. So that's where chemotherapy is pumped into the abdomen. So you, I guess many of us have or have had chemo ports, or sometimes called PICC lines. So like basically a plastic tube that goes into your body, and it's got a block of plastic on the surface end, so that it's easy to kind of inject chemo into. So with HIPEC, you have 2 of those placed on your abdomen, and heated chemotherapy is pumped in, and it kind of circulates in your abdomen and is pumped out. And this is done in some procedures up to like 24 hours, pumping this heated chemo around you, and you're conscious. And then you have, well, yeah, that could be before or after cytoreductive surgery, which just means surgery to remove all the visible cancer that can safely be removed. So that's also a form of hyperthermia therapy. Even though they're using chemotherapy drugs, there does seem to be a hyperthermic effect. Now, hyperthermia, where you're bringing up the tissue to maybe what's called fever temperatures. So I'm afraid I don't know the imperial system, but for metric, there's like 41 degrees Celsius, to bring the tumor or cancer cells up to that kind of temperature. That damages the cells. It causes protective proteins to form on the cells, which your immune system can then target. Those are called heat shock proteins, and there are many different kinds, but conveniently the different kinds are different sizes, so they're just like referred to by the diameter of the protein in nanometers. So the key one for fever temperature hypothermia is HSP 70, heat shock protein 70. It's kind of forming on the cells, on the cancer cells, and getting damaged by your immune system afterwards. So finally, treatment 8 is the metabolic therapy. So that's trying to inhibit the cancer metabolism, or kind of to starve it of energy, to kind of damage it, like force it onto a less efficient metabolic pathway. But also cancer tumors, so they metabolize with anaerobic respiration. As we remember from school, when you're just walking around or jogging along, you're in aerobic respiration, so that's when you've got enough oxygen. When you do really intense exercise, your muscles work anaerobically, so they're not in the presence of atmospheric oxygen, but using oxygen inside the cells and blood, but not like free molecular oxygen. So the side effect of that, which we all know, is lactic acid. So that's what causes like the muscle burning and stuff in your muscles when you do intense exercise. And there is this idea that when cancer cells are metabolizing, because they're producing this lactic acid, that's kind of surrounding the tumors, like building up around the tumors. And it seems that that environment, what's called the tumor microenvironment, is very important for modulating the immune system. And on a very crude level, just when the white blood cells are trying to get in, I think they like die in the lactic acid or something. Metabolic treatments are often done using off-label drugs. So that means you're using a drug that is developed for one purpose and has been repurposed. So these are called repurposed drugs or off-label drug use. The one I took was metformin, which is a diabetes drug, but there are a whole bunch of other ones. I personally, just based on talking to research about this, it does seem the effects of metabolic treatment are very small. In my case, the reason I did metformin for quite a few years actually is because it's very cheap and safe, and I was having immunotherapy at the time. So if the reduction in lactic acid around the tumors, if that helps the immunotherapy a bit, it's an incredibly cheap way of getting more for my money, really. So if I'm paying for this really quite expensive immunotherapy, and a certain percentage of those white blood cells are just dying in this acidic microtumor environment, or tumor microenvironment, sorry. It seems sensible that if I can take this old cheap diabetes drug and make it a few percent more effective, then obviously I chose to do that. So those are kind of the 8 main ways of treating cancer. There is some overlap. So for example, there's some radiotherapy done during surgery. There's a whole kind of blurring between immunotherapies and targeted, like molecular targeted therapies. There are kind of odd things like cryotherapy, where you're freezing the tumors to death. That's included in hyperthermia therapy for some reason. And there are like other odd things. So lots of hospitals will do RFA in the radiology department because it's like scanner guided or ultrasound guided. So anyway, that's just like a run through of the treatments. And the treatments available to you depend on the origin of the cancer, the location of particularly where it's spread to. The size of the tumors matters quite a bit. The number of tumors, so that's changing for some things, but for example, with radiofrequency ablation, the kind of rule of thumb in the past was that it was only worth doing if there were 3 or fewer tumors in the liver, and the largest diameter of the largest tumor was, I think, 30 millimeters. That's changed a lot recently in countries that are doing a lot of RFA. They found benefit from doing RFA even when there's tens of tumors in the liver. They found benefit of doing it even when there are really quite big tumors, because maybe, you could shrink a tumor to a point where surgery became safe. If you imagine a tumor, say someone's got a liver tumor pushing against the portal vein, the surgeon looks at the scan and says, sorry, can't touch this. You may be able to get it shrunk with RFA and maybe chemo as well. One of the really good points of radiofrequency ablation for the liver is that it doesn't reduce your liver function, so you can continue chemo just as normal. So as I said, yeah, they do kind of overlap. Your health makes a big difference to what treatments you can have, obviously with surgery. So surgery, surgeons will talk about this thing called PS, or performance status. And performance status is like, really, are you fit for surgery? And part of that is like, are you going to do okay during the surgery? But I think part of that is also the recovery. So, with surgery, you talk about like the chance of not surviving the surgery, but then also the chance of like serious problems after, particularly in that first 30 days. That's called morbidity. And of course, mortality is the chance of making it through the surgery. So performance status is things like, it's often in the questionnaire, it's often, it will be assessed to some extent by the surgeon, but mainly by the anesthesiologist. That's like, are you okay going up and down stairs? Can you take care of your like daily life? Are you, are you extremely bedridden? And that kind of influences a lot what surgery is safe to do, and also what is worth doing. But one thing I found from looking at patients who are long-term stage 4 survivors of colon cancer, because those are the patients I mainly talk with, things do change. So there are plenty of cases, for example, like me, where I had an inoperable liver, and it became operable later on. Now, that's not because my performance status changed, but it's because the cancer in the other parts of my body were dealt with through immunotherapy, molecular targeted therapy, hyperthermia therapy, radiotherapy, and a bunch of other stuff. So it's really important when you're told no for a treatment that you realize the chances are they're saying no at that point in time based on your current situation. In the case of surgery, it's also really reflects the surgeon's situation. So if you're told no for surgery, if you're told you're ineligible for surgery, or you have inoperable lymph nodes, so let's say para-aortic lymph nodes, so there's kind of like, like back, knee, or spine, like close to the aorta coming from your heart. Tricky place to be removed by surgery. But another surgeon at a different hospital with a different team, maybe who specializes in that, may be able to do it safely. So you do have to be a bit careful when people are saying no for treatments. Be extra careful if it's the oncologist saying it, not the specialist, because let's say, your oncologist may have gone to talk to a radiotherapist, maybe at a team meeting, if you're in the UK, where the team system is used at every NHS hospital. There could be a lot of information and reasoning why you're not eligible for that certain treatment. But if you had the details, you might be able to find a different option. There might, for example, with radiotherapy, there might be a different form of radiotherapy you could do. If you've had radiotherapy before and then you're rejected on the grounds that you've already had radiotherapy, it'd be too much radiation, you may be able to find a different mode of radiotherapy which is safe to do. So we do have to be skeptical. We do need to kind of push a little bit. We have to be very careful when thinking about viable treatments, because we're usually being told answers based on economics and big statistics. And that's to do with what treatment tends to work over time for the average cancer patient. what's worth the money for the government, or, let's say you're in the US, then it's what the insurance company will pay for. And they have exactly the same kind of thinking and reasoning. But we're concerned with our situation, and it could be that a treatment that's not viable to do for the general population could be having that treatment may give us a good result that opens up other treatments. I am speaking very much from experience there, because that's exactly what's happened in my situation, that treatments opened up the possibility of other treatments. So I guess the next thing to talk about really is the intent of the treatment, and we need to find out, is it curative? For some reason in radiotherapy that's called radical intent. I have no idea why. Maybe they just think it sounds better. Or is it palliative? So trying to extend life or make you more comfortable if you have tumors pushing against nerves, that kind of thing. But if you're accessing very advanced treatments, this line between like curative and palliative is very, very blurred. I had treatments that in most countries would be considered palliative, but because it was a combination of treatments, it has potentially been curative. I've had palliative treatments that opened up options for other treatments that have been radical in intent. So the lines blur, particularly when you're getting really good new treatments. It's kind of old thinking, like palliative, curative, this kind of thing. Understandable, but yeah, old. Obviously, we're balancing the risks and the benefits, but as I said, you need to think about the risks and benefits to you, not the risks and benefits to a typical block of 10,000 cancer patients in your position, where someone's deciding what drug to be, funding, or someone at an insurance company is deciding what's worth paying for and what's not. We're concerned with our personal situation, and yeah, we have to base it on our situation, our tumors, our spread of cancer, not the statistics for making, difficult economic decisions. I'm not having to make these difficult decisions about what drugs to fund and what drugs not to fund. But when it's my health, my life, then I have to guide the specialists to not turn away from treatments that they read in a medical journal as being, not economically viable, because I'm just thinking about me. It's just one person. When we kind of compare treatments, we're generally looking at the MOS, the median overall survival. So you'll hear sort of people saying, well, the median overall survival for this treatment was, say, 9 months, and the best current treatment median overall survival was 4 months, and therefore you should do this treatment. Be very, very skeptical of these stats. If you know about stats and you're interested, it's eye-opening to dig into them a bit. You can say, how many people are in that study? Are there any other studies that support that or contradict that? Are there any reasons why that study may not apply to me? So I had a liver surgeon tell me it was too dangerous to do liver surgery for me because I had had radiotherapy to my liver. And he produced a graph from a paper. And I said, okay, well, so this graph was about like people doing liver surgery and after radiotherapy, and then tumors coming back, and not just tumors in the liver, but throughout the body. But it was a study of 300 patients. It was, I think, like from 12 years ago, This is from a couple of years ago when he was showing it to me. And it was also not patients where the colorectal cancer had spread to the liver, which is my situation. It was primary liver cancer. So, yeah, I politely told the surgeon that this was of no relevance to me at all, and went to see some surgeons who were able to do the admittedly dangerous, difficult surgery in my case. And they did a fantastic job, and I lived to tell the tale. So we do have to be careful with these stats, because medical professionals do tend to pick stats that support their way of thinking, which again is understandable, right? If you're a radiologist, you think radiotherapy is really good, and of course you're gonna you're just naturally going to remember the studies that support the treatment that you think works best. So, there's confirmation bias, there's availability bias. So availability bias is the idea that we believe what we can remember, and of course that's deadly. But if you're a specialist in, say, cyberknife, and you're reading journals every month on radiotherapy, the articles on cyberknife are naturally going to pop out at you. You're naturally going to remember them more, because cyberknife is what you deal with every day. So you're going to have an unconscious bias towards that. So as patients, we do have to be really careful of this kind of thing. To some extent, we can prepare ourselves for some of these treatments. I've had 3 big surgeries, and I will be talking about surgery in the surgery module, obviously. But the 3 classic things for preparing for surgery is to get the weight down, stop smoking if you smoke, stop drinking if you drink. I know they're all easier said than done. I only found out, like, just around the time of my last big surgery, I found out that if you want to lose fat from the inside of your body, then that fat responds much better to exercise than to reduced calorie intake. So I had been reducing my calorie intake quite a bit, and this was because my surgery was going to be very deep in the pelvis, and men tend to have like a deep, narrow pelvis. So there's not a lot of room for this in this situation with this was reconnecting intestines. There's not a lot of room for the surgeon to be poking around. All your organs in the abdomen are like got protective fat on them, but yeah, if you need to make more room for a surgeon to have an easier job, then you want to concentrate on exercise for that. The other big thing we can do for surgery is prepare the heart and lungs as much as possible. This is one where unfortunately things are a bit easier for men than women. Male body responds a lot better to hard exercise for heart and lungs than female body, although obviously female body responds too. But unfortunately females have to work a bit more for the same gains, which is unfair, but that's what evolution gave us. So getting the strong heart and lungs makes a big difference, and any heavy exercise will help a lot. So I did running up and down steps with ankle weights on. When I say running, let's be honest, it was fast walking, but it seemed to make a big difference. Physical strength is also something that is worth building up. I don't see any reason why that would help during the surgery, but often after surgery we're in bed a lot and you lose strength really, really, really quickly, scarily quickly, just by being in bed a lot, especially in hospital, but even when you go home and you're, feeling pretty frail. So you want a lot of strength before you go into the surgery. I found particularly, getting the leg strength up, because you're going to be a bit unstable on your feet, and getting grip strength up, especially if you've had a lot of chemotherapy, which tends to cause peripheral nerve damage. Just kind of a weird one, but for radiotherapy, it's really worth asking what position you're going to be in the radiotherapy. You'll usually be shown this in the preparation days for radiotherapy. So often radiotherapy, you need something that keeps your body in a certain position. So you'll go and they'll make that for you, or they'll scan you or measure you, and then make some kind of thing for you. In my case, for proton beam therapy, it was like a kind of a mattress. So I think they scanned me, and then they make this unique mattress. And interestingly, on my last day of proton beam therapy, when I was looking around I was taken on a tour of the machine, and they showed me a room where they keep all the mattresses. They have to keep them for a certain number of years before they can be disposed, because I guess they're radioactive. With tomotherapy, which is another type of radiotherapy, for the preparation day, I had to lie down on, again, it was kind of a mattress, but this was, I think, full of sand, and they had a way of locking it in shape. So I was kind of pushed around to get me in the right position, and then I guess they pumped out the air from this sand-filled mattress. They call it the backlock. But the reason I mention that is that often for radiotherapy, you might have your arms above your head, and if you're in a radiotherapy where it's scanner guided, so you have to be in exactly the right position, and that takes a while to get in that position, and you have to lie there for a while during the radiotherapy, and then you have to stay in the position while they kind of check that the targeting was okay. It can be quite a strain, so it's really worth, if you've got tight shoulders, it's really worth doing some exercise to loosen them up. And the way you do that is you go to a sports physiotherapist, and you explain you're having radiotherapy, and you show them how you're going to have to lie, and they will give you some exercises that you can do every day. You generally get pretty good results in 3 weeks. So if you can find out 2 or 3 weeks before and do those exercises, just to make sure that you're comfortable lying in an awkward position for extended periods of time. And that's true regardless of the targeting. You might have to have your legs in a weird position or whatever. I struggled a lot in Japan because the beds tend to be a bit short for me. I'm not particularly tall, but I'm definitely taller than the average Japanese citizen. So sometimes I was in weird positions with foam blocks under my feet and stuff, and not very comfortable. So that's a very small thing you can do for preparation, but makes a big difference. Another big way to prepare for certain cancer treatments is going to the dentist. Really worth doing. Some hospitals, that will be part of what they do for your surgery, for example, or radiotherapy. When you have radiotherapy anywhere near your mouth, it increases the chance of cavities forming. So it's really important to go to the dentist for that. When you're doing surgery, particularly those longer surgeries, your mouth is wide open for a long time. It's got the airway forced in. My surgeries were generally, I think, 6 to 8 hours. So a very high chance of infection from your mouth. Very easy to pick up pneumonia, because essentially parts of the lung are exposed, more exposed to the air than they usually would be in the course of your usual breathing. So that's really worth doing. If you're on chemo, or if you're going to be on chemo, again, it's really worth going to the dentist first, to have everything checked and have really good cleaning done. because again, like one of the side effects of most chemos is that it can be like wound healing is impaired. So you can't do like tooth extraction, even like having dental work done might cause a lot of bleeding. So going to the dentist before really does help a lot. Unfortunately, with some chemo and molecular targeted therapy, you also get a lot of gum trouble. So again, you really, really want to go to the dentist first. Another big bit of preparing for treatment is planning your recovery. I mean, this is most relevant for surgery, but planning how you're going to deal with stuff after surgery, particularly those first few weeks. So some kind of recovery plan, maybe you want to involve friends and family in that. Surgeons encourage you a lot to walk straight after surgery, particularly abdominal surgery, early standing, early walking, early eating. It's very unpleasant, but it's been really proven to make a big difference in reducing complications afterwards. Things like getting that deep breathing going as quickly as possible helps prevent the pneumonia. On the subject of pneumonia, so I got pneumonia after my first 2 surgeries, and then I thought, why am I getting pneumonia? Why don't I go and get a pneumonia vaccine? So I paid the money to get the pneumonia vaccine privately, and it's only, I think it's something like 80% effective, and fortunately yeah, I didn't get pneumonia for the 3rd surgery, which was nice, because the second time I got pneumonia I got collapsed lung as well, which wasn't so fun. So a bunch of ways you can prepare for surgery, and I guess, yeah, I'll just go over some side effects. I mean, I think we're all very familiar with like hair loss from chemotherapy is like a classic one, also to some extent from radiotherapy as well, but that does depend a lot on the chemo drugs. So many common chemo drugs don't cause hair loss. In the UK, particularly for the gynecological cancers, there's a lot of emphasis put on preventing hair loss by like wearing an iced cap. I've read some of the data on that. I'm pretty skeptical. I don't know why it's such a big thing in the UK. I haven't really heard of it much in other countries. But the idea is that like you wear an ice cold cap during the chemo, and that reduces the circulation in your head. So, you know, let's say it's chemo for breast cancer or ovarian cancer, less of the chemo is going to go up into your head. The reason that chemo causes so many side effects, including hair loss, is that chemo targets dividing cells. So anywhere in your body where cells are dividing, now of course for adults we're not growing, hopefully, but that's things like lining of your mouth, the skin cells, hair follicles, all the lining of the GI tract, so stomach lining, intestines, obviously. So that's why chemo tends to cause the diarrhea, the constipation, those kind of problems, skin problems. Skin care is really important for many cancer treatments, radiotherapy, because you get kind of burning and stuff, but also even surgery, just because you're often in kind of an environment of like canned air for extended periods of time. So taking care of your skin is really important, and nurses are fantastic about that kind of thing. Yeah, so that is an overview of cancer treatments and the effects. Other side effects, of course, just the nausea. That's a really hard thing to deal with. I found that just every time I talk to a medical professional, I'd say, I vomit very easily. Please just give me everything to stop the vomiting and nausea. and that was relatively effective after a while. I should say, yeah, with surgery as well. If you're someone who does vomit easily like me, if you've never had surgery before and you're having surgery, it's really important to tell the anesthesiologist that, because they will put an anti-vomit drug when you come round. So surgery number 2, I had the anti-vomit drug, and of course, when surgery number 3 was happening, they said, have you vomited before from surgery? And I said no, remembering surgery number 2, forgetting I'd had the anti-vomit drug. So of course, surgery number 3, vomited a lot afterward, which was really painful. Yeah, don't do that. Have anti-vomit drugs. It's really helpful. So yes, future sessions, I'm going to go in detail over types of radiotherapy, types of surgery, different molecular drugs, different chemotherapies and their effects and side effects, and go over some of the hormone therapies, hyperthermia therapy, like the HIPEC I mentioned in this module. Yep, so please join me for those too, and I hope you found this one useful.